questions.
How does something like clinical athlete fit into that equation where you guys have like a massive network of providers that are also, a lot of them are also coaches, right?
Yeah.
And like outside of the obvious, like I can see where coaches might be hesitant to approach someone like you or who is in that position of they're a coach, they coach exactly like I do, and they're a PT. If I send my athlete there, he's going to poach them.
Yeah.
Or it's like, how do you with clinical athlete, how does that fit in, and how can a coach utilize clinical athlete?
Well, I'll tell you, if the PT's model is poaching clients, they don't tend to stay around that long.
Obviously,
like,
right.
You know what I mean? So
Yeah.
I would like to think that had that been a clinical athlete provider, you would have heard from that provider, and or that provider would have understood the demands of their sport, and you would have gotten much different. You would have actually had the conversation in that context, because it wouldn't have been an exit conversation. It would have been maybe that client approaches one of you coaches at the gym and just like, hey, this is what my PT said. Like, they still want me to lift, but we're going to go off blocks or go to squat to pins or whatever,
Right.
Whatever the issue is. And so I think it is, first of all, the people in our network are biased towards athletes, and they're athletes themselves. That's kind of what our thing is, walk to walk. So they understand the athletic demands. They're not scared of them.
It's not the churn and burn PT model.
Right.
Exactly. And they're not going to say squatting's bad for your knees, because that PT has a squat session right after their shift, or you know what I mean? So they understand the demands, and they are also, even if they have a client list themselves, respectful of, part of our process that we train them on is defining your role. And if that athlete that you're going to work with has other stakeholders involved, you need to figure out where you fit.
Right.
And poaching clients is not part of our process
For sure.
of training. And that's just it. But it doesn't happen. If they've got a coach, I'll just take myself as an example of the clinician. I'm reaching out to the coach, or the coach has already reached out to me, or if the coach is hard to get to, I'm on the athlete constantly about, show this to the coach, let me know what you're doing still, because a lot of times they're still on a program on the back in the background, and I'm making as sure as possible that my program is complementary and not redundant or even conflicting with the stuff that they're already doing. So it's extra work. Like, it doesn't make it actually easier.
Yeah.
But it helps the outcomes, and it creates buy-in, because the person doesn't feel so confused, like they're getting different
So like
messages.
best case scenario for a coach who has an athlete that's hurt, they could reach out to like clinical athlete and say, I think, or maybe they have that client like, hey, you should reach out to these guys. I think they can help you. That person would maybe schedule a call, and then like if you guys work together, it's a collaborative process where there's a little bit of communication between you and the coach and the athlete, and because I imagine some people are like say a higher level where they're really like pushing for maybe qualifying for an event or something, and so there's a need to continue the process of training. Obviously, they buy into what's going on. They know they don't need to stop totally, but they also need to make sure that it's not like a prescriptive, like, here you go, do these 4 exercises twice a week and then call me in 6 months.
Exactly.
Right.
And the coach so what's helpful in that scenario too, if there's another coach, so defining your role is one thing, but defining done is equally as important. So if they're going to go back to the coach, if the expectation is, I am going to go back to my old training program and my old coach, you're just in the interim right now, you have a specific role to help us get back on track. You have to keep your thumb on the pulse of defining when that threshold is going to be, like when you're going to hand the baton completely back off.
Right.
And oftentimes it's very arbitrary. Like, it's not, hey, I'm hitting PRs and my thing is completely gone now, and I'm the best athlete that I've ever been. Still under my care. Like, that's usually not the case. We define done as, we've got you back to the point now where you can head back to that direction.
Right.
And that's where, so I have to talk to the coach of like, at what point would you feel comfortable programming for this person again, knowing that they are still kind of dealing with this? It's not completely gone, but the momentum is very clear in the right direction. And we figure out a cutoff. And maybe it's like, if they could train squats 3 times a week at 80%, I would be very comfortable still managing like some of the load, but I just want them to be able to get back to like a normal schedule, handle the schedule, and then the dosing of progression the coach can handle. So we define whatever that is going to be.
Right.
And it's a lot of times arbitrary cutoffs, but it's not arbitrary to us because that's what we decided on.
Right.
So with clinical athlete, like obviously, like I trust you and your company, and I've seen what you've done over the last decade. If I have a client come up to me and they're like, Zach, I've got this knee issue or whatever, and I recommend clinical athlete, for the coach listening to this, the client then maybe goes, oh no, I got this guy through Kaiser I always see, or like this other guy I usually see. How should that conversation go if we want them to see our guy,
Yeah, I think, again, it's treading lightly. It's not, oh, that guy's going to, no.
Yeah. No.
Unless it's an individual, like, straight up,
ruined.
you've already had experience, like, their name, and
Yeah.
you're like, please don't.
Yeah.
I get that. But you explain, okay, cool, because you don't know anything about that person. Maybe the person at Kaiser is fantastic.
True.
I mean, honestly, like, it's where there's great
That's
PTs
a
out there.
big maybe.
There's, I know, we're
Big
like
maybe.
name dropping. Something bad's going to happen.
Yeah,
we're all gonna get
defamation suit. Yeah.
Yeah, exactly.
Straight to you.
Oh shit. Okay, but all you can do is explain what you hope they get out of a PT. So you can say, okay, cool, and like based on however that goes, let me know. Keep me updated on how that goes, what they say. Also, if you want, I've got options for you in terms of PTs who are power lifters and like no power lifters and trained power lifters themselves. So if that doesn't work out, or if you want a second opinion, let me know and we can set that up too. So I think it's not like breaking down their wall and bursting their bubble right off the bat, but it's planting that seed that you can come back to, and then keeping your thumb on the pulse, like checking in with them to see what narratives are being explained and
During my cancellation call.
yeah, because if you go in, you're going to go in like I get the skepticism.
Yeah.
But if you lean into that too much, no matter what that PT says, you're going to be like, I don't know what they're talking about. And then it's kind of going to like the person can kind of sense that even when you think you're being open.
Yeah. And then they get offended, or whether they tell you or not, they get offended,
Yeah.
and then they move on.
Because what if they're excited? Like they just
Yeah.
came from that PT visit and actually had a
Right.
good visit, and
Yeah.
they're feeling good about it, and you kind of like poo-pooing
Yeah.
on it a little bit.
So one of the questions I want to ask you was the role of pain in training. So like there's discomfort, there's injury, and everything in between.
Yeah.
And from a coaching standpoint, again, with a lot of coaches listening here, the three of them that listen to our podcast, of course.
The rest are all
How
We have 6 listeners on Clinical Athlete Podcast.
Yes.
So.
Okay, cool. All right, we're almost there. We're half the way, and you've been doing that for 10 years or something like
Yeah.
that. So good. What should the coach be looking for? What should the communication be around pain? What does the role of pain play in training? I just would love to hear your thoughts on this.
Yeah, another really good question. It's very gray too, and also kind of scary because there's like coaching education is like pain equals injury equals healthcare. Like stay within your scope, and like that's also true. But let's forget like the being scared of getting sued and just kind of talk about like pain and as just a physiological experience and the person and you as a coach or a clinician, but you're just trying to manage this person. I think if you feel like it is outside of your scope and you feel uncomfortable with what they're telling you in terms of the experience, that's your first order of business of referring out, is like your skill set and your comfort level with managing this. So just across the board, if the person's telling you that their foot's going numb, or they're like their leg is feeling like tingly or weak, or they're like have lost control of their bowel and bladder, then that's an emergency. So
It's a powerlifting meet.
Yeah, well, that's normal powerlifting meat.
That is true. Abnormal loss, though, if it's a thing that happens
Right.
regularly,
During the
then
bench
that's
press.
not normal. Yeah. Okay. That would be something.